Check the accuracy and completeness of the medication administration record, MAR, with the practitioner's original order. Ensure the 6 rights of medication safety. If applicable, use organization barcode system to ensure medication administration accuracy. Assist the patient to a comfortable sitting or supine position at a level for easy access. Change the patient's gown to an easily removable gown with snaps at the shoulder if available. Prepare prescribed IV solution. Check IV solution to verify that prescribed additives, for example potassium, vitamins, have been added. Check solution for color, clarity, and expiration date. Check solution bag or bottle for leaks. Prepare infusion tubing. Open infusion set, maintaining sterility of both tubing ends. Using sterile technique, add extension tubing to IV tubing if desired to allow for more length, enabling the patient to move more freely while still keeping IV line stable. Ensure that the correct IV set is at hand. A special dedicated administration set is required for some electronic infusion devices. Place roller clamp below the drip chamber and move roller clamp to off position. Prime the system. Remove the protective sheath over the IV tubing port on the plastic IV solution bag or the top of the bottle. Remove the protector cap from the tubing insertion spike, being careful not to touch the spike. Insert the spike into the tubing insertion port of the IV bag. A second port may be used for additional IV medications and electrolytes. If the IV solution is in a glass bottle, clean the rubber stopper on the bottle with a single-use antiseptic wipe and insert the spike into the black rubber stopper of the IV bottle. Prime the infusion tubing by filling it with IV solution. Compress the drip chamber and release it, allowing it to fill 1/3 to 1/2 full. Remove the protector cap on the end of the tubing. Some tubing can be primed without removing the protector cap, and slowly open the roller clamp to allow fluid to travel from the drip chamber through the tubing to the needle adapter. Return the roller clamp to the off position after priming the tubing, filling it with IV fluid. Be certain the tubing is clear of air and air bubbles. To remove air bubbles, firmly tap the IV tubing where the bubbles are. Check the entire length of the tubing to ensure that all air bubbles are removed. If using multiple port tubing, turn the port upside down and tap to fill it and remove air. Replace the cap protector on the end of the infusion tubing. Attach a short extension set with needleless connector per organization's practice. Swab injection cap with antiseptic swab. Insert syringe with saline flush solution and inject through the needleless connector into the tubing. Label the IV bag and IV tubing. Apply a label to IV bag or bottle that includes type of solution hung, date, time, and nurse's initials. Avoid writing directly on the IV bag or bottle or using a marking pen to label it. Write only on the label. Apply a label to IV tubing that indicates either when tubing was hung or when tubing should be changed. Perform hand hygiene and don gloves. Don eye protection and mask as appropriate. Maintain aseptic, no-touch technique. Identify accessible arm vein for vascular access device. Check for presence of radial pulse. Open all sterile packaging using sterile technique. Apply flat tourniquet around arm above antecubital fossa and above the proposed insertion site. If possible, position the tourniquet over a thin layer of clothing, such as a gown sleeve. Reposition the tourniquet lower down the arm to access a vein in the hand or lower arm. If using a blood pressure cuff instead of tourniquet, inflate cuff to a level just below patient's normal diastolic pressure. Maintain inflation at that pressure until venipuncture is completed. Select the vein for vascular access device insertion. If available, use vein visualization technology to map the vasculature and make assessing and finding a suitable vein for IV access easier. Use veins found on the dorsal and ventral surfaces of upper extremities. For example, cephalic, basilic, and median veins. Use the most distal site in the non-dominant arm if possible. Clip arm hair with scissors if necessary. Avoid areas with risks for complications. Select a vein large enough for a vascular access device. Choose a site that does not interfere with patients' activities of daily living or planned procedures. Locate a well-dilated vein. Foster venous distension by stroking the extremity from distal to proximal below the proposed venipuncture site. and by applying warmth to the extremity for several minutes, for example, with a warm washcloth. With the index finger, palpate the vein by pressing downward. Assess the vein for resilient, soft, bouncy feeling while releasing the pressure. If possible, place the extremity in a dependent position. Temporarily release the tourniquet or blood pressure cuff. Apply a local anesthetic, for example, intradermal lidocaine, topical transdermal anesthetic, vapocoolant, as prescribed or per the organization's practice. Place adapter end of infusion tubing or extension or injection cap for saline nearby on sterile gauze or sterile towel. Place towel under the patient's arm or hand to protect bed linens. Cleanse the area of insertion. If the skin needs cleansing, use soap and water first and then allow the skin to dry completely. Prepare the insertion site with greater than 0.5% chlorhexidine in alcohol solution, using a back and forth motion for a minimum of 30 seconds, and allow the site to dry completely. If chlorhexidine is contraindicated, use tincture of iodine and iodophor or 70% alcohol. Allow iodophors to dry a minimum of 90 to 120 seconds. When using povidone iodine for children with compromised skin integrity, allow it to dry completely and then remove it with sterile normal saline wipes or sterile water. Maintain aseptic no-touch technique. Do not touch the insertion site after skin antisepsis unless sterile gloves are donned. Reapply tourniquet or blood pressure cuff above anticipated insertion site. Check for presence of distal pulse. Perform venipuncture. Anchor the vein below the insertion site by placing thumb over the vein and gently stretching the skin against the direction of insertion distal to the site. Warn the patient to expect a sharp, quick stick. If using an over-the-needle catheter (ONC) with safety device, insert with the bevel up at a 10 to 30 degree angle slightly distal to the actual site of venipuncture in the direction of the vein. If using a winged needle, hold needle at a 10 to 30 degree angle with bevel up slightly distal to actual site of venipuncture. Observe for blood return in flashback chamber of catheter or tubing of winged catheter, indicating that bevel of needle has entered the vein. Advance catheter. Lower catheter or winged needle until almost flush with skin. Advance catheter or winged needle slowly into the vein. If using an ONC, loosen the stylet. Continue to hold skin taut while stabilizing needle and advance catheter off the needle. Thread just the catheter into the vein until hub is almost at insertion site. If using winged needle, advance cannula until hub rests at venipuncture site. Stabilize catheter with one hand and release tourniquet or blood pressure cuff with other. Apply gentle but firm pressure with middle finger of non-dominant hand above the insertion site. Keep catheter stable with index finger. Remove needle and stylet, activating safety devices as indicated by catheter manufacturer. Place needle and stylet directly into sharps container. Maintaining sterile technique, quickly connect end of the prepared intermittent IV device or the continuous infusion tubing set to end of catheter. Secure connection. Do not touch the point of entry at the connection. Flush injection cap on the intermittent IV device or begin infusion by slowly opening the slide clamp or adjusting the roller clamp of the IV tubing. Secure the catheter. If using a manufactured catheter stabilization device, clean selected area with single-use skin protectant wipe and allow to dry. Slide device under catheter hub and center hub over device. Holding catheter in place, peel off half of liner and press to adhere to skin. Repeat on other side. Holding catheter in place, pull the tab out from the center of the device to create an opening and insert catheter into slit. This frames the IV site. If the plan is to use a sterile gauze dressing, place narrow piece of sterile tape over catheter hub. If sterile tape is not available, apply non-sterile tape around the catheter hub or stabilization device. Place tape only on the catheter, never over the insertion site. Observe the site for swelling. Apply sterile dressing over the site. For a sterile transparent dressing, carefully remove adherent backing. Apply one edge of the dressing and then gently smooth remaining dressing over IV site, leaving the connection between the IV tubing and catheter hub uncovered. Remove outer covering and smooth dressing gently over the site. Place a wide piece of tape over extension or administration set tubing. For a sterile gauze dressing, place a 2 by 2 inch sterile gauze pad over the insertion site and catheter hub. Secure all edges with tape. Do not cover connection between IV tubing and catheter hub. Fold a 2 by 2 inch sterile gauze pad in half and cover with wide tape extending past the gauze pad. Place under the tubing or catheter hub junction. Curl a loop of tubing alongside the arm and then place a second piece of tape directly over the tubing to secure. For IV fluid administration, recheck flow rate and correct drops per minute and connect to an electronic infusion device. Label the dressing per the organization's practice with the date and time of application and the nurse's initials. Trace tubing or catheter from the patient to point of origin before connecting or reconnecting any device or infusion, at any transition, for example, new setting, and as part of the handoff process. Do not force connections and avoid workarounds per the organization's practice. Label the tubing at a connection site closest to the patient and at a connection site closest to the source when there are different access sites or several bags. Check vital signs immediately after making any connection per the organization's practice. Instruct the patient how to move or turn without dislodging the vascular access device.